Hello everyone and welcome to today's lecture on neuropsychotoxicology. So, there are innumerable substances which can be included under the term neuropsychotoxicology. But this lecture concerns itself only with some of the relatively important or common examples encountered in toxicological practices, such as barbiturates, benzodiazepines, phenytoin, lithium, neuroleptics, and tricyclic antidepressants. As we embark on today's journey, we confront the ominous specter of barbiturate poisoning. Barbiturates are white, crystalline, odorless powder with a faintly bitter taste. Barbituric acid was first synthesized on 6 December 1864 by Adolf von Baer, a German scientist. He did it by condensing urea with diethyl malonate, which is derived from apples. Classification of barbiturates. So, they are classified under 4 categories. One is long-acting, intermediate-acting, short-acting, and ultra-short-acting. If we talk about the examples of long-acting, they are phenobarbital, methylphenobarbital, and phenytoin. Intermediate-acting are allobarbital and amobarbital, that is sodium amytal. Short-acting are cyclobarbital and seconal, while ultra-short-acting are pentothal sodium and camethyl sodium. Fatal dose. For short-acting barbiturates, the fatal dose is 1 to 2 gram. For medium-acting, it is 2 to 3 gram, or for intermediate-acting. And the last one, for long-acting, it is 3 to 5 grams. If we talk about the fatal period, it is of 1 to 2 days. Coming to toxicokinetics. So, these barbiturates rapidly absorb from GIT, including the rectum. After ingestion, these barbiturates are preferentially absorbed from the small intestine. They are concentrated in liver for a short time and then evenly distributed in the body fluids. After that, these barbiturates are eliminated by hepatic and renal systems. Mechanism of action. So, barbiturates are CNS depressants. They depress the neuronal activity in the midbrain reticular formation. They facilitate and prolong the inhibitory effects of GABA and glycine. Coming to clinical features. First, central nervous system. As it is a CNS depressant, the symptoms are drowsiness, which is the earliest symptom. Then ataxia, confusion, delirium, hallucinations, headache, nystagmus, which is lateral and vertical, paresthesias, slurred speech, vertigo, visual disturbances, and finally stupor progressing to deep coma. If we talk about signs, then the Babinski toe sign is positive, loss of response to painful stimuli, pupils will be slightly contracted, and there will be reaction to light, but they will be dilated, maybe unequal, during the terminal stages. That is because of hypoxia. And lastly, the superficial as well as the deep reflexes are inhibited or completely lost. If we talk about the respiratory system, then these barbiturates causes a depression of the medullary respiratory center, which induces respiratory depression leading to bronchopneumonia and respiratory acidosis. Respiration will either be rapid and shallow or slow and labored. Coming to cardiovascular system, the skin will be cold and clammy, there will be cyanosis, hypotension, and weak and rapid pulse. Lastly, skin or dermatological findings is cutaneous bulla, that is also known as barb burns or barbiturate blisters. Treatment. First of all, gastric lavage should be done with warm water mixed with KMNO4 and suspension of activated charcoal or tannic acid. In barbiturate poisoning, emesis is contraindicated. We can give enema also to evacuate the bowels. There is no specific antidote for barbiturate poisoning. Urine alkalinization can be done. Hemodynamic support can also be given for hypotension. Other than that, hemodialysis or hemoperfusion can be performed. Along with all these, we have to see for symptomatic treatment. Autopsy findings. First of all, there will be signs of asphyxia. As for example, there will be congestion of all internal organs. Cyanosis will be there. Along with that, petechial hemorrhages in lung and on pleura and pericardium. Nose and mouth will show frothing. Skin will have barbiturate blisters. Lungs will be intensely congested and may even be turned completely black, that is full of dark deoxygenated blood. Stomach will show congestion as well as erosions. If we talk about kidneys, then there will be degeneration of the convoluted tubules. And lastly, the brain will be edematous. Medico-legal importance of barbiturate. First, it is a popular drug as an agent of suicide. Secondly, if we talk about euthanasia, then these barbiturates are a popular drug for even euthanasia. Thirdly, barbiturate automatism. Now, what is this barbiturate automatism? So, any drug automatism is repeated intake of a drug because of drug-induced drowsiness and amnesia. So, in this, the person forgets that he has taken the drug, so he will keep on taking the drug repetitively, and even he can die in one single night. Moving on to the next medico-legal importance, it is a drug of abuse because of psychological symptoms it produces. Especially the short-acting and intermediate-acting are preferred. Next medico-legal importance is it is used in narcoanalysis as truth serum. Lastly, for judicial execution, it is used by the method of injection. A sequential drug combination of sodium thiopental, that is a CNS depression, and pancuronium bromide, which paralyzes the respiratory muscle, along with potassium chloride, that is used for cardiac arrest, is used. Now, moving on to the next term, that is benzodiazepines. So, these benzodiazepines are psychoactive drugs whose core chemical structure is the fusion of a benzene ring and a diazepine ring. The first benzodiazepine, that is chlordiazepoxide, that is Librium, was discovered accidentally by Sternbach in 1955, and it was made available in 1960 by Hoffmann-Roche. It also marketed diazepam, that is Valium, since 1963. Coming to the uses of benzodiazepines, so it is used as an anti-anxiety drug. Along with it, it is also used as a muscle relaxant as well as sedative. Common preparation of benzodiazepines are alprazolam, chlordiazepoxide, diazepam, flurazepam, and lorazepam. Coming to the fatal dose is 100 to 300 milligram per kg. So, because of high dose, the death is extremely rare if taken alone. It may cause death if taken with alcohol or other potentiating drugs. Coming to mechanism of action, it enhances the inhibitory actions of the neurotransmitter GABA, which is located in the brain. Clinical features, the symptoms are divided into two, that is symptoms for acute poisoning and symptoms for chronic poisoning. In case of acute poisoning, symptoms appear within 1 hour, which are ataxia, shallow breathing, diplopia, dysarthria, sedation, slurred speech, nystagmus, somnolence, staggering walk, and vertigo. Coming to chronic poisoning, long-term administration with high doses, as for example 30 to 40 milligram diazepam daily, produces chronic poisoning. Withdrawal symptoms occur on sudden withdrawal, which are anxiety, headache, insomnia, muscle spasm, psychiatric disturbances, tremors, anorexia, and vomiting. coming to treatment part of benzodiazepine poisoning. First of all, decontamination with the help of gastric lavage, emesis along with activated charcoal. Other than decontamination, we have to give intravenous fluids. The antidote for benzodiazepine poisoning is flumazenil. Then other than that, we have to correct the hypotension, and along with it, forced diuresis and hemodialysis are ineffective. Lastly, the medico-legal importance of benzodiazepines. First one is behavioral disinhibition. What is this? The long-term benzodiazepines use lead to behavioral disinhibition, which may induce a person to hostile acts, aggressive behavior, and verbal indecency. And the second medico-legal importance is date rape. This benzodiazepine is also used as a date rape drug to induce amnesia. Moving on to the next and the last drug of today's lecture is tricyclic antidepressants. Before the SSRIs, the TCA, that is tricyclic antidepressants, were the first line of defense against the depression. Today, tricyclics are less popular choice than SSRI, but they are still important drugs for patients who don't respond to anything else. The first tricyclic to be developed was imperamine in late 1950s. Most widely used TCA today is amitriptyline and has at least equal efficacy against depression as that of SSRI. Coming to mechanism of action of TCA or tricyclic antidepressant, they block the neuronal reuptake of norepinephrine, serotonin, and dopamine. There is also blockade of myocardial sodium channels. And along with it, there are also anticholinergic, adrenergic, and alpha-adrenergic blocking effects. Moving on to clinical features, it produces sinus tachycardia. QRS and QT intervals will be prolonged. There will be hypotension, then ventricular dysrhythmias, grand mal convulsions, and coma. Treatment of tricyclic antidepressants. emesis is contraindicated because coma or seizure may develop abruptly. We can give gastric lavage as well as activated charcoal. IV sodium bicarbonate are also given for metabolic acidosis and cardiovascular complications. We have to treat the hypotension on general lines along with dysrhythmias and seizures. Last, the medico-legal importance. These tricyclic antidepressants are used usually for suicidal purposes. Even child neglect or abuse should be considered if the patient is less than 1 year of age. And lastly, the serotonin syndrome, which is produced because of concomitant overdose with a MAO inhibitor, which leads to severe toxicity. So, in this section, first of all, we will take neuroleptics. Antipsychotics were earlier called as neuroleptics. Now, classification of neuroleptics, they have been classified into phenothiazines, butyrophenones, thioxanthines, other heterocyclics, and atypical neuroleptics. Example of phenothiazines are chlorpromazine, triflupromazine, mesoridazine, thioridazine, and flufenazine. If we talk about the butyrophenones, example are haloperidol, penfluridol, and trifluperidol. Among thioxanthines, we have chlorpromazine, clopenthizol, and flupenthizol. Among other heterocyclics, we have loxapine and pimozide. And talking about the atypical neuroleptics that are second generation antipsychotics, we have clozapine, loxapine, olanzapine, and risperidone. Fatal dose is 2 to 5 grams. Mechanism of action. All antipsychotics except the atypical one have potent dopamine D2 receptor blocking action. Antipsychotic potency has shown good correlation with their capacity to bind to D2 receptors. Blockade of dopaminergic projections on the temporal and prefrontal areas constituting the limbic system and in mesocortical areas is responsible for this antipsychotic action. Coming to clinical features, first, eyes. In eyes, we will see corneal opacities as well as miosis. While in CNS, there will be sedation and seizures. CVS, we will be having myocardial depression, orthostatic hypotension, and ventricular tachycardia. In respiratory system, we will be having laryngospasm. If we talk about blood, then there will be agranulocytosis along with hemolytic anemia. Skin, we will find dermatitis, gray-blue pigmentation, photosensitivity, and urticaria. In males, gynecomastia and priapism can be present, while in females, there will be amenorrhea. Coming to the treatment part, MSAs and gastric lavage can be done. Then we can give multiple dose activated charcoal, that is MDAC. Catharesis can be performed and the whole treatment should be symptomatic. Coming to the next drug, that is phenytoin or diphenylhydantoin. That is phenytoin, along with its derivative, that is fosphenytoin, mephenytoin, and ethotoin, is an anticonvulsant used in the treatment of all types of partial and tonic-clonic seizures. Phenytoin is also used in the treatment of ventricular arrhythmias, especially digitalis-induced. Coming to the mechanism of action of phenytoin. So, phenytoin is a hydantoin derivative, a first-generation anticonvulsant drug that is effective in the treatment of generalized tonic-clonic seizures, complex partial seizures, and status epilepticus without significantly impairing the neurological function. Phenytoin works by blockade of voltage-dependent membrane sodium channels responsible for increasing the action potential. This action obstructs the positive feedback that sustains high-frequency repetitive firing, thus preventing the spread of the seizure focal point. Coming to the clinical features, gingival hypertrophy occurs in about 20% of the patients at the therapeutic doses, and it is due to altered collagen metabolism. There will be subcapsular cataract formation in chronic use with phenytoin. Phenytoin is a known teratogen and can cause a number of defects in the newborn, together referred to as fetal hydantoin syndrome. There will be increased risk of neural tube defects, cardiovascular defects, oral cleft, and urinary tract defects. Treatment. First of all, decontamination. Decontamination is done with stomach wash and the activated charcoal. Then, stabilization. Cardiac monitoring is advisable following the parenteral overdose or rapid infusions. We have to treat the heart block with the help of atropine or pacemaker. For seizures, in case of paradoxical intoxication, use diazepam. If seizures persist or recur, then we have to administer phenobarbital. And after that, supportive measures we have to take. As for example, hypersensitivity reaction may respond to corticosteroids. So the last drug in neuropsychotoxicology is lithium. It is the lightest of all the heavy metals. It is the drug of choice even today for the treatment of manic depressive psychosis, that is bipolar affective disorder. Coming to the mechanism of action of lithium, lithium induces changes in sodium transport within nerve and muscle cells, and it also influences the metabolism of neurotransmitters, particularly catecholamines and serotonin. It may alter intracellular signaling via second messenger systems by inhibiting inositol monophosphate. This inhibitory action subsequently impacts neurotransmission mediated by the phosphatidyl inositol secondary messenger system. If we talk about clinical feature, then there are three types of lithium poisoning. First one, acute poisoning in patient not under the lithium treatment. Secondly, acute poisoning in patients under lithium treatment. And thirdly, chronic poisoning under lithium treatment. The acute poisoning not under the lithium treatment is mild or moderately severe, while acute poisoning in patients under lithium treatment is very severe. Coming to the acute poisoning, in gastrointestinal tract, we will find nausea and vomiting. If we talk about the central nervous system, we will have weakness, vertigo, tremor, twitching, hypertonia, ataxia, muscle rigidity, drowsiness, slurred speech, confusion, myoclonus, convulsions, CNS depression, and lastly, coma. In cardiovascular system, the QT interval will be prolonged, and ST and T wave will show anomalies along with hypotension. Along with all these, we will have leukocytosis as well as polyuria. Now coming to the chronic poisoning, in gastrointestinal tract, we will be having nausea. In central nervous system, we will be having Parkinsonism, psychosis, amnesia, photophobia, and blurred vision. In case of cardiovascular system, we will be having myocarditis, T-wave changes, bundle branch blocks, bradycardia, junctional rhythm, and hypotension. Along with these three systems, we will be having aplastic anemia in case of blood. If we talk about the renal system, then there will be nephrogenic diabetes insipidus, interstitial nephritis, and renal failure. Among endocrine, we will be having hypothyroidism, and in skin, we will be having dermatitis, ulcers, localized edema. Coming to diagnosis of lithium toxicity. First one is blood lithium level. So the toxicity is associated with levels over 2 milliequivalent per liter. Death is likely if this BLL crosses 5 milliequivalent per liter. If we talk about the therapeutic levels, it generally ranges from 0.6 to 1.2 milliequivalent per liter. Lithium is easily measured by atomic spectrophotometry, ion selective electrode, or by emission photometry. In lithium toxicity, we have evidences of hypernatremia, hypocalcemia, and hypoparathyroidism. We can also perform the urine analysis and determine the serum creatinine to rule out the impaired renal function. Now lastly, the treatment of lithium toxicity. First of all, we have to stabilize the patient. In stabilization, we first maintain the airway, breathing, and circulation. Cardiac monitoring should be done. And in case of hypotension, infuse 10 to 20 milliliter per kg of isotonic fluid. Then after stabilization, next step should be decontamination. So in decontamination, stomach wash can be given, whole bowel irrigation can be given. This whole bowel irrigation should be given with a balanced PEG-ELS, that is polyethylene electrolyte solution. And after stabilization and decontamination, we have to do the third step, that is elimination enhancement. This should be done by hemodialysis. Thank you.